So just want to go through a few housekeeping things before we dive into the content. This webinar is being recorded, so you'll have access to it later. We're asking that you don't use a speakerphone as it creates some funny audio, and also not to put us on hold so we don't hear your hold speaker or music in the background. And also we ask that you mute your phone when you're not speaking. And if you're on the phone today, you can do that by pressing *6 and doing the same to unmute yourself. We also ask that you participate today. We have lots of good state team discussion planned, so we want you to speak up and we want to have discussions with you. You can send any tech issues to me via the chat box, and I'll answer those for you. If you have any content questions or want to contribute to the conversation, please send those to the whole group, and we'll either read those from the chat box or we'll ask you to speak up so that we can engage in that conversation. We also want you to link your phone with your computer, which I'll show you how to do in this slide. You can simply type in or dial in your meeting ID and then participant ID on your phone. And one last housekeeping plug is that we ask you to share your video during the discussion portions, especially so that we can engage with you that way. We want to see all of your faces. So with that, I will pass it on to Bethlyn to talk about the agenda today.
Great, thank you, Libby. First off, I just want to give a grateful acknowledgement that people are on this webinar when there is so much going on. And we're hoping that this will be a value add for you. We have, as you may have probably seen in the many different types of communications going out, and amidst your many communications, I'm sure, we have our COVID-19 and CMC Echo launched this week for the CoIIN teams, and then we have an external one coming next week. And we have some pop-up webinars, and this is a regular webinar. What we're hoping to do to kind of distinguish this from some of the others is kind of take everything going on that you're grappling with, that you're trying to do immediate response to the real-time needs. Consider that and then try to say, like, all right, so where are we coming from? Where's the resilience, leadership in the context of your quality improvement projects? And call from each other in that context right now as you're trying to pivot and move forward. So that's what we're trying to do here. And to that end, we're going to start with consideration in public crisis. Greg will be able to share around past times when another instance when he was involved with quality improvement project and how we might consider that as you move forward, recognizing there's going to be this big event that happened, and now what when you're looking at, particularly when you're looking at how you're measuring your success. And then we were talking about, we wanted to have a little discussion antecedent to that, precedent to that around your own evaluation considerations and what you think we as the BU team should be considering and trying to capture at this moment, realizing that it's a very different moment than we found ourselves in earlier this year. So we want to talk about that with you and make sure that we're considering things that are really meaningful and matter as we move forward. Then we're going to look at some themes that have been coming out of the redesigned reports, monthly reports. We wanted to just pull in some themes for you and consider in particular from the teams, and then look at that also from the perspective of families in particular and their experience, because that's really at the foundation of everything that we are doing. And then we're going to move into consideration of how we're building resilience and just conversations on that and questions that you have for each other. Some of them are more specific, but we're hoping to use that to build upon for larger considerations for your projects and moving forward. And then we just wanted to check in on what you might think would be useful to get into. The pop-up webinars are really meant to be more focused in a particular area to meet real-time needs. So we wanted to see what might be of interest for that, and then we're going to carry on. So that's it. So I'm going to just hand over the torch to Greg and go from there. Thank you.
All right, thanks, Bethlyn. Can everybody hear me okay? Does it sound okay?
Yep.
Oh, good. Okay, thanks. that silence worried me there. Anyway, great to see a lot of your faces, and especially knowing what you all are going through and being here today. It was just really rewarding to see all of you who could make it. I do want to give just a heads up before I start that I am going to be talking about something that might be bring up some emotions for people. It was the context of my story I'm going to share was during the 9/11 terrorist attacks in New York City. And so I know that brings up some strong memories for me. So I just wanted to also give you guys a heads up. But anyway, I'm going to start off by sort of showing my age here because this was, almost 20 years ago when I was working on this project, and I was doing similar work that I'm doing today with you. And it was actually a very similar initiative I was working on. It was a childhood asthma improvement collaborative based in New York City. And it was about 15, as I recall, 15 or 20 different New York City hospitals who were focused on improving childhood asthma in their outpatient clinics and mostly in the outpatient clinics there. But anyway, very similar to our CoIIN, and about halfway through, I don't know if I can control the slides here, but
You can just say next slide and I'll move on for you.
okay, yeah, thanks, Libby. Can you move on to the next slide? But in the middle of, smack dab in the middle of the collaborative, the terrorist attacks in New York City occurred. And it was just devastating, of course, for everyone personally and in this work that we were trying to do together in New York City. However, there was sort of a bright, this was a bright memory for me because I was very inspired by what happened next. In the sort of the following weeks and months as our hospitals that we were working with were kind of getting their legs underneath them and things, they were really dedicated to continuing their work. We sort of expected some of them may have to drop out. They had a lot of things going on, obviously, besides the improvement work they were doing, but all of our hospitals wanted to continue the work. And they were even saying things like, this just makes our work even more important, stuff like that, because of changes in the air quality and things like that in New York City. And, other comments like, we can't let this stop us. This is too important. So anyway, they were very dedicated to the work they were doing, despite the challenges that they were facing, both personally and professionally at the time. And what came next was really quite remarkable. I'll never forget. The teams kept meeting, they kept making changes, they were doing typically monthly data reporting, and they continued to do their data reporting. And in fact, I remember this brought me to tears when I was working on the project. The first month after the terrorist attacks, all of our hospitals, as I recall, all of the hospitals had submitted their monthly data that month. And I was just blown away. I was expecting much, much less than that. But it just shows you the dedication they have. The other thing I wanted to sort of share in my story, besides how inspirational it was, and before I sort of shift gears to the data, because this certainly affected the data, I just want to say that, our hospitals were adapting and pivoting just like you guys are. We were doing the same. And it was really a great working relationship, a collaborative working relationship that built between us, the TA support, and the teams doing the work on the ground in the hospital. So it really brought us together, and we all sort of had all hands on deck kind of a feel and move forward together. But anyway, as we started looking at the data in those first month after the attacks I mentioned, there were some surprising things in the data, some very remarkable changes based on looking at the trends they had before, and some were expected and some weren't expected. So one of the unexpected ones was that there were some measures around the patient experience, patient waiting times, things like that, and those for many of the hospitals dropped 20 to 30 points that next month, and they had been increasing in general. So that was surprising. There were also some outcomes that changed, but weren't surprising. It was kind of expected, like they did see, I think, an increase in ER visits or admissions to the hospital in the month or two after the attacks, but that was kind of expected. So they really did want to drill down on these unexpected data though. So they did, various hospitals had different approaches, but they did things like start talking to their patients, interviewing them, if you will, During some of the visits, they had questions for them about their ratings and what had changed in the past month. Some of the hospitals just added open-ended questions to their survey, trying to dig a little deeper there that way. I think one or two even did focus groups, trying to figure out why are our patients perceiving the sort of, not just the waiting times, but their experience in the clinic differently. What they found was reassuring as they talked more and more to folks. Like most people say, well, nothing's really changed. I guess I was stressed out that day or something. So it definitely had an impact on how people were viewing things, even though the sort of the conclusion after talking to families and patients that nothing had really changed in the clinic and their experience hadn't changed. And a lot of them would say things like, I didn't know I rated any lower, but maybe I was just stressed out that day, that kind of thing. So anyway, that was that was reassuring to see on those surprising figures. And indeed, like in the months after that, they did see those previous positive trends return. So it was just like a blip for a few months in those measures after. But you know, it's not surprising that lots of things can change when you're measuring something and something catastrophic like this hits. Oh, the other thing I'll mention about before I move on is another thing that the teams found really important was to annotate their graphs. They were doing run charts like you all, and make sure that they annotated either on all of the graphs or at least the ones that were affected when the 9/11 was, and how, you know, that sort of helped them be able to look at their graphs and tell their story of improvement. You could see how on some measures, 9/11 certainly had an impact on things like waiting times and things like that, but then they improved and got even better than they were before the attacks. So, so really, that was really great to see, and the annotations really did help tell that story. Okay, could you go to the next slide? Thanks, Libby. So anyway, working with you all during this pandemic feels like a very similar crisis to that time I was telling you about roughly 20 years ago. And there are a lot of similarities. It's kind of bringing back memories for me working right now during this pandemic. So one of the things that really stands out to me is I see the same spirit and passion in your teams that we had in those hospitals in New York. And so I'm just so inspired by you guys dealing with so many challenges in your work life, in the families you're helping, the children you're helping. It's a very, very challenging time, but you guys are still adapting, pivoting, hanging in there. And it's just, like I said, it's very inspirational. And then just like in the New York City project, I would say we probably will see some unexpected changes in our data. You guys are going to be looking at that soon. So be on the lookout for that. You may need to dig a little deeper on some of the things, like some of the things you may be able to anticipate. This is probably going to change in this direction or whatever, but there may be some unexpected things, and that's where you want to dig a little deeper. So, you know, again, like the hospitals I mentioned in New York, I think probably the most useful way to dig deeper is some qualitative data. You know, you might just be talking with families and asking them some questions during visits, or your staff, things like that. Another thing is, specific to our collaborative, we do have a lot of composite measures that have multiple questions on the survey that are built into those. So I'm sure you guys already do this, but, you know, just be even more, I guess, scrutinous of the individual responses that make up those, especially if you see a change in your composite measures that you weren't expecting up or down. You may want to dig a little deeper with the individual questions and see which, if any of those were changing in a big way. That can be very helpful to learn and sort of, again, use really to drive future improvements that you're making in your work. Another thing you might be able to add some open-ended questions to existing surveys you're already doing, like with your staff and things like that. So anyway, I think the combination of really drilling down at all the measures, especially the ones where they're embedded in a composite measure, and doing qualitative data assessment when you do see something unexpected will be important. And then finally, just like we did in the New York City Collaborative, I think it'll be important for all of us to annotate our graphs, at least either all of your graphs or at least the ones where you see some kind of effect potentially from the pandemic, both now and in the future. So, you know, we've talked about this before. You not only want to annotate things that you're doing and changing in your systems or processes, but you also want to annotate things that are unexpected and out of your control. And so this pandemic is certainly having a major effect on you all as well as your families and children that you're caring for. So I'm sure we're going to need to annotate our graphs, many of them. And then the final thing that my reflections kind of brought up was, you know, we're there with you. We have your back, our BU collective team that's working on the CoIIN. So please don't hesitate to ask how we can be helpful. We're trying to be as flexible and as adaptable as you guys are. I'm not sure we can, but we'll try our very best to be as flexible and adaptable as you all are in handling this and work with you to make your work in this time much more, hopefully, easier for you as you move forward. So let's go to the next slide, Olivia. I just had a couple of questions. It'd be great to hear some discussion or comments from you guys. I just threw out a couple here to maybe trigger some thoughts. But one is, what are some of your aha moments or learnings so far from working during the COVID-19 pandemic on this work? Also, anything that you've seen unexpected in your data or data collection thus far? I think some of you may have even had a preliminary look at some of your data. I'm not sure, but definitely in the data collection, it can be affected. But anyway, anything you'd like to share with your peers and colleagues? Love to hear these or any other questions for discussion.
And I think folks have the ability to take themselves off of mute. Is that right, Libby? Yeah, don't have to wait for us.
Hi, it's Mary Ciccarelli from Indiana.
Hi, Mary.
I think one of our first aha in COVID was that we did not have a method to communicate in a broadcast fashion with our patient registries. And when we wanted to communicate a lot of new issues around COVID, like resources that they should be looking into, it was difficult to communicate it because we were not seeing them in the office. They weren't coming into the office to see thick signs we have posted in the office. And so we suddenly needed a method that we didn't have. We decided as the fastest approach was to turn back to our Family Voices and About Special Kids organizations, because they are very good at using their Facebook pages and their newsletters to help communicate with families. But we had not aggressively recruited our families to make sure they were participating in those resources. And so we had lag time in not being able to turn that on immediately, and wished retrospectively we had done a better job with that. And so it just highlighted something we had in our hands that we weren't using.
Mm-hmm. Great, thanks for sharing that. I really like that you had sounds like some important learnings, and I think all of you are, things that maybe you didn't realize before this happened, and it's shown a light on some things that are maybe weaknesses or strengths, like you said, and good things to know about. And then also, I really love the way you guys collaborated with your families to work on getting the messages out. So that's a great example of really involving families in this work.
Great. In a second, we had one other. Oh, I'll let somebody else go. If there's time, I'll tell you one other aha.
Mm-hmm. Okay, thanks.
Greg, this is Tammy Bakewell in Oregon.
Hi, Tamara.
Hi. I just wanted to follow up on Mary's comment, and it was not specific to our CoIIN. I will say that, so I'll just make this really brief, but one of our clinical situations also reached out to us as a family organization about a really specific part of that communication, which was the issue of blocked phone numbers coming into families from providers working from home using their personal cell phones. And it was, so we got together as a huddle, our parent partners, and said, what are we going to say? We understand privacy. This is a big deal, but these are unusual times. What do we want to do? And so as a group, and granted it was a small group, there were only 6 of us together, but we said, I think we need to tell parents, pick up your phone for now when you get a block call that you don't recognize. And anyway, it took a little going. I think families finally did start, being able to understand that if you don't pick it up, you might miss an opportunity to connect clinically, and that could delay things. But the phone calling stuff was a big aha that hit early on that family organization tried to help with. I don't know how successful, but we tried.
That actually feeds right into what my second aha was, Tamara. So I'll jump back in if it's acceptable.
Oh yeah.
We had to start exploring tons of different ways of using telehealth that we had never used before. We were not up and ready to go. It was so much torturous, whole different conversation. But we were able to turn on a texting function to families, and it's a good way to communicate. People read their texts when they don't answer their phone. And most portals don't afford you that ability. So that was an interesting aha, the value of texting. We don't have a lot of data on that yet, but we're going to try to measure that.
Mm-hmm.
And then Doximity Dialer is a site that you can block families to see your cell phone. It reads as if it's you're calling from your office. And so we learned to use that so the families would still recognize the phone number.
Great.
Because instead of using star 67 or whatever else people are using to block.
Greg, I think Jill McCormick has her hand raised.
All right, Jill, can you unmute or?
I can. I don't have a way to show you, but I can talk to you. I think some of the things that we have been doing that are specific to COVID, and Shonda and Cindy can kind of jump in if they would like, is we knew we needed, or we felt like it would be good to really look at kind of what's the difference in the interaction that families are having with the navigators and with Gabby and Nate as they enroll them from the NICUs, is looking forward and back. What was there a shift in how families accessed resources, asked for resources, and interacted long-term with the navigators? And then what was their participation level? Did it change from pre-COVID to now? Were they more engaged before or now? Did they ask more questions before, or do they ask more questions now? What was the engagement level for our families in participating in the program? And then just kind of looking at the enrollment levels itself, just what are the numbers NICU-wise pre and post-COVID? Are there more babies? Is it the same? Just those were kind of some of the things that we've started looking at and kind of wondering and kind of building our information around.
Great, thanks for sharing that. And I think I'm at time. I'll ask Bethlyn to weigh in here, but I'm at time, and I'm also thinking this might be a good transition to the next part where we start talking about some of the evaluation aspects. But
so yeah, Greg, we do have Debbie. She had her hand raised, and I would like to let her speak. So maybe we can do that, and then we'll move into the next. They all really kind of go together. They're just coming at the same stuff from a different angle. So we can continue this conversation and move into the next slide too. Go ahead, Debbie.
Thanks. So this is Debbie from Kentucky. And actually, I was just going to comment on what was already said. As far as Kentucky also came to the realization that we did not have an effective means of communication, of communicating with our families like at a broad level. And we were, I think just relying like on Facebook to get out messages, but that's not really reaching our families. But I personally have had good response with whenever I've contacted families, and I call from my personal cell phone and block the number. And I think I've only had a handful of patients that don't pick up.
Great. Thanks for sharing. And I'll hand it over to you, to Bethlyn, if we want to transition into the next.
Yeah, so I think that these can kind of go together. So what we're talking about is some of the ways in which you've been having in front of you from really pragmatic considerations as you're trying to navigate through this situation. So in consideration of that, ways you're finding to innovate and be able to reach out, that could end up potentially having be a lasting improvement to the system, right? And then looking at one of the next question Greg had was unexpected. What you're seeing is unexpected in your data. So when you consider those things, part of what we want to talk through is there anything that you see from our end on the network level that we should be looking at and or approaching from an evaluation standpoint, like in how we look at the data as we move forward? So thinking about your quality improvement project, what would your suggestions be in relation to that? And you obviously, anything further that you feel like would be useful to share in context of that from your own projects, we'd love to just hear so that we can consider that right now and be responsive at this. It's just an unprecedented moment to be able to bring in those learnings. So I don't know if anyone has thoughts on that.
Bethlyn, it looks like Judy Palfrey has.
Oh yeah, thank you. Great, so Judy, you go right ahead. Let's see if you need some help unmuting.
I mentioned this yesterday at the ECHO meeting, but not directly from this project, but from many conversations with others around New York and Philadelphia and Massachusetts. The role of community health workers has never been so important, and they are just doing incredible things for our families, and particularly for our families with special health care needs. And the trust that they have established with the families is way higher than some of the physicians are saying, I couldn't get through, but so-and-so called or dropped by or whatnot. And oh, by the way, they do drop by. They will bring food, they will work out homes for people, et cetera, et cetera. So I don't know if others are working with community health workers, but I think this is a time really to document their extraordinary contribution to our healthcare system. And particularly for those of us that are working in places where there are huge health disparities, this is a way to really address many of those problems.
Thank you, Judy. Yeah, I Meg asked a question just considering around kind of taking that and extrapolating out to consideration of any other collaborative relationships as we're seeing the new partnerships, as we're seeing the role of someone that's really going out into the community during times of crisis, and that may look different for each state who's in that role, but I imagine that in each state there's someone that's been going in to really try to meet families where they're at. And Shonda, do you want to speak to your comment here? You're talking about how confident families are. Would you mind speaking?
Yeah, so just giving a broad scope of asking families how confident they are in reaching out either individually for resources, whether it be social needs, food, housing, or whether it be medical complexity needs. We have had an uptick, in my experience with our CoIIN families, of can I still go to my regular doctor right now to get G2 placement? Or can I go to the emergency room with my baby? Is it safe? Where do I go for? And there's a lot of questions around because of the environment we're in, and they don't know where to reach out. And so equipping those families and getting them some tools in their toolbox so that they feel confident enough to, at even a basic foundational level, know how to get their needs met, and then helping them grow from there and getting them, geared up to be able to support themselves, because this is, obviously going to last for a while, and we want to make sure that our families are equipped with some knowledge and some tools. So I think that maybe giving some data on the beginning of COVID to maybe the end of the year, and seeing if we're able to help those families grow their resource toolbox to be able to get their needs met. And also the peer support piece too, making sure that was on the ECHO as well, making sure that they have social supports and peer supports for emotional health, and for someone that they can reach out to that they feel comfortable being transparent with.
Yeah, that made me think, as Greg was talking about the idea of one of the ways that the healthcare team in the 9/11 crisis was looking is through qualitative data. And I wonder if we take back some of this and consider something we might be able to add to focus groups, so we could provide a few questions and you could pick, like, hey, maybe we'll add this to our focus group because this one works for our team. So you can consider some of these if they make sense for you as you're trying to look at what's going on for your families. And then we could pool together, for those that choose those ones, we can pool together those responses too. And then we do have another chat here. Mary, you're saying, oh, nope, I went up too high on me. Sometimes it gets really quirky. Oh, is that from you, Meg? Do you want to just say what you're saying here about a way to tie this together? I think that would be helpful for people to hear.
Sure. So I was just thinking, I'm trying to draw out of the conversation that we're having things that we could be doing to be helpful to you all. We're definitely very much aware that the last thing our state teams probably need right now is more things to do and more measurement requirements. So we're trying to be very careful about that, but we're also trying to think of ways in which we could be more helpful to you in our own measurement and evaluation work. And so one thought I had is about the changes in the requests and questions that the care coordinators are getting. So are there new buckets of need that folks are hearing about? What strategies are the state teams using to address those needs? And then how do you measure the outcomes of those strategies? I'm just wondering if the state teams think that might be a helpful target for us to think about providing you support and assistance around if you wanted to do that.
Hi Meg, hi everyone, this is Shreya. I'm the project coordinator for Team Oregon. And yes, to your question, I would like to add that it would be very helpful if you added as part of the the larger evaluation, if we were able to describe how we had to modify our project overall in response to COVID-19. Because we want to be able to describe that our university halted all non-essential research, so we were not able to enroll, but we actually used the time to discuss how clinic operations may change after everything restarts. Also focus on the payment and financing strategies. OHSU has dramatically expanded its telehealth capabilities during this time, and so how we are trying to leverage that, understand the nuances of billing and payment associated with that. So yeah, it would be nice if we were able to describe those, and either in the monthly reports or qualitative questions for the team leads. So yeah, I just wanted to put that out there.
Thank you. I feel like that's some validation for some things that we're already starting to do. So this was a topic in our last evaluation team meeting. What kinds of lessons learned can we draw from this experience that can help inform future public health crises response? in the context of quality improvement. And also, Anna Maria is going to be part of an evaluation team meeting coming up in the near future to help think through from HRSA's perspective what they would like to learn from this experience, what would be helpful to them. So I think we're very much in line with that thinking. Thank you.
And we were also thinking, you made me think of this, Shreya, it's this very helpful conversation for how we can try to integrate and pull this together without more work for you. And so there's a value add and really responsive and feeds back into what you're doing throughout the network and in your individual projects. And one thing we were thinking was taking the monthly reports and pulling from that and pooling it and then feeding that back to you, because that is a place where we're going to be collecting real-time like responsiveness that you're doing and what you're learning, and then we can feed that back to the teams, and we can pull things out for like pop-up webinars and try to make it really simple so people aren't doing more work and they can just kind of talk, but if they've got work to highlight. But that was another idea, was then we can feed that back to you all in real and like turn it around within the next week so that you can see what other teams are doing in these areas, and we can keep, if you think of other ideas for what we could be collecting within the context of that monthly report, we'd be more than happy to keep tweaking that along the way. Like reopening is coming up. So that's another thing that everyone's been thinking about and how that's going to progress. So we have just a few more minutes for this portion, and I don't want to do all the talking. So I do see that Denike, am I saying your name wrong? I apologize if I'm pronouncing it wrong, but you mentioned here moving forward to have a plan and do a survey about how the providers met or exceeded expectations. Do you want to speak to that a little bit? Let us know what you're thinking.
Sure, no problem. And Adenike is fine. You
got
it, and thank you.
All right.
No, I think it's important. You know, we always get caught up in the reactive, and we get caught up in the fact that we weren't able to actually do proactive. It makes us feel some type of weird way as providers and educators and anybody who works with people, I think. But I think it's just important because we've got the situation that we were dealt, we have the hand that we have, it makes sense to proactively and reactively think about what this looks like at the end, and glean as much information as possible. Because with research, it makes it really difficult to go back after the fact and be like, oh man, we missed it. We should have asked, we should have thought about. So if we put those hats on now, collaboratively together and try to think about, well, what questions can we ask? And the biggest one I thought about right now is, did we even meet the expectations? I mean, keep in consideration that everyone was caught off guard. How did we do? Like, honestly, as providers, did we provide what you needed? Did the resources actually follow through? Like, you were promised these resources. When you connected with these partners, did they do what they said that they were going to do? Were your needs still met? Did you have to go somewhere else? Some of those questions make sense to ask in the midline right now and also in the end, and then looking for the unsolicited advice to kind of further identify anything that we could potentially use in the future as we're looking forward to making sure that if something like this will happen again, something similar, unfortunately, as the world turns, but maybe it won't feel so abrupt if we can have a plan in place, a protective plan in place and use the information that we have right now to get through it.
You have a way with words. Meg, is there something you want to say in response to that?
So just a couple things. One, I saw at least one thumbs up validation for that comment. So that sounds great. I think one of the things that I've found personally to be a tent pole in terms of resilience is to know that whatever it is that's terrible that's happening now, something can come out of it that will be of use later. So that's one way to sort of, if we use an appreciative inquiry approach where we're looking for those things that are working now, we're looking for those things that are strengths, and we want to figure out ways to build on them, to get more of those things, to make them stronger. That's one way to think about it. If I were to sit down and think about all the things that I've done wrong in the context of COVID-19 response in the past couple of months, it would be a long list and it would be really, really depressing. So I think maybe, you know, if we just turn that on its head a little bit as a network, it might be helpful to all of us as just one more piece of our resilience toolkit.
Great. Thank you, everybody. This is a lot of excellent thoughts, and it gives us a lot to work with. And we will, as Meg mentioned, we'll continue to look at where we could integrate different pieces, including we're going to be having a call with our evaluation team. And is that this week? I don't even remember where things are anymore, but yeah, that's coming up. And so we will continue. And if you have any other thoughts, feel free to throw us an email, throw them in the chat box right now. And we're actually going to move right from this into just talking through some of the things that we've been hearing from you all, and just really kind of trying to lay bare some of the dynamics and factors at play to help us consider our way forward and the resilience and leadership and where we go from here for families and really for all of us. But so I'm going to hand it over to Meg, Kara, and Debbie, and I think that Meg's going to start us out with a few slides, and then Kara, and then Debbie.
Thanks, Bethlen. I don't want to talk too long because I know you'd much rather hear from Kara and Debbie. I just wanted to make a couple of high-level comments here at the start. One, we wanted to thank you very much for the work that you all are doing in continuing to get your monthly reports in. And the quality of the information that you're sending us has been so impressive to us. Thank you very, very much for that. We are just incredibly grateful for the learning opportunity that you're giving us and continuing to fill out your monthly reports and fill them out with lots of thoughtful comments, lots of thoughtful suggestions for us. So thanks for that. We've learned a few things from the data that we've been getting from you all in those monthly reports. Some of it has been around emerging needs. So the things that Mary and some of the other folks were saying earlier about contacting families during a time when it's difficult to do that. Some folks are expressing the fact that there are so many different players trying to give them resources. They're a little overwhelmed by all of them. It's sort of, how do you triage? What would be a helpful thing to actually take advantage of when it's just a deluge? By the way, thank you very much for doing the echo yesterday, so many of you, and then again the webinar today. It's a lot in 2 days for one project, so thank you. Evaluating telehealth from the family perspective to help inform policy moving forward. What things are working well for families that we want to try to keep in the future post-COVID, and what are the things that didn't work that we want to just sort of let go and think about ways to change. Some of the state teams are reporting innovations, and we wanted to just highlight them for 1 second. Alabama is doing curbside pickup of acknowledgement forms for survey completion. So that's something new and different that they've taken the initiative to go ahead and do so that they can keep collecting their data. Washington State has the Family to Family Health Information Center Facebook group that I think was mentioned just now. Indiana is the state is providing payment to family caregivers if they're out, if their other supports are out, families in the home can get that payment in order, because they're doing basically the same job. So there are some things that are happening on the state level that are innovative that I think our state teams are helping connect folks to. And there are other things that the state teams are taking the initiative to do themselves to help better serve kids and families in this difficult time. Libby, let's go ahead and switch to the next slide. We're as always, going to share these slides with you all in addition to the recording after today's webinar. So you'll have access to all this information. We won't take the time to go through it now, but we're tracking the themes that we're hearing from you all, from your families, from the things that we're hearing from our family leadership partners, from the things that we're hearing in other sort of projects and other sort of venues, and really trying to gather that information into a single place so that we can really see the breadth and scope of the things that are happening for kids and families right now. Many of these things, if not all of them, will some way, shape, or form get transferred into echo sessions. So stay tuned for more on these. let's go ahead and switch to the next slide. And now I'm going to turn the floor over to Kara Coleman and Debbie Harris, who are going to talk a little bit about the experience of families from the perspective of families right now. And so take it away, Debbie and Kara.
Thanks, Meg. Hi, everybody. First, I'm going to have to ask for no laughing at the image on the right. I am not the artist in my family, but as I was thinking of how to process and take all the information that were on the 3 slides before and in all your reports, and then in the weekly calls that we're having with all of our F2Fs and state affiliates, it's just a lot of information. And I went to one of my favorite tools of all time, the Care Map. And Meg had the brainiac idea to compare a pre-COVID care map. So I went back to Kristen Lynn, the grandmother or grandpoobah of all care maps, and then created on the right here, you know, a smack dab in the middle of COVID-19, what does this care map look like? And my thought here was trying to express, you know, in the frame of coping and resilience and leadership. And it's so great to hear, Greg, thank you for sharing about 9/11. And I did feel myself getting emotional. My voice may crack a little in this because that was emotional. And this is emotional now. And I was trying to reflect that very poorly in this. And now I'm going to mess up your name. Adenike? Hopefully I got it right. But your just thoughts of being proactive and reactive. And what I was trying to reflect here is the reality of what shelter in place looks like for children with medical complexity and our families. We've had to all, and providers and professionals and everybody, we're all in this little small unit here, and everyone and everything is on the outside. But when we're doing, you know, trying to take care and support and provide care, it feels like these big walls and barriers, and how do we come over it? And you feel like you have to climb up and climb over and figure out how to barrel through and what to pour in and put in. And you're hearing, you know, just the frustration that you're also probably feeling working from home and balancing homeschool, and that families are feeling, and then the needs are higher, and just how do you balance everything? And how do you bridge this divide? You know, we talk a lot about the fragmentation of the system, the gaps, the brokenness, and that's what this QI project is trying to do. And how do we do it when it's more shut down? All of the things on the left of the code of the care map on the left are still a part of the world, but they're shut down so drastically. And so when we talk about needs, like for example, the mental health needs of families that are providing all the care themselves, what do? Do we just start, you know, sending in more providers and figuring out ways? I'd like to think that for families, or I know for families and for providers and for all of us alike, I think we can take a lot, and it sounds like people are really doing it. And it sounds like from what Greg shared that what they did, you know, during 9/11, and what many of you are doing now is fighting that time, using the time to talk through, well, what do you really need? What do you really want? You know, acknowledging really the moral distress that we're all feeling with this broken system that has all these chasms, and how can we come together? How can we lead with communication? How can we come together with communication? And just thinking about that appreciative inquiry response that was just suggested, you know, and looking at, did we meet expectations? Now we have time too, a little bit more time to even talk about, well, what are expectations? You know, when you're sharing about telehealth doesn't work for me, or I'm afraid of it, or can we just do it this way? Or I don't want any caregivers in my home. Why? What? You know, let's go further. How do we make everything work together? What are the expectations? What are the needs? So hopefully you find something in my my rendering of this COVID-19 care map, and how do we bridge the gaps and come together and work on making connections that people need, and respecting the space. Sometimes maybe we need space, and maybe more like there's great innovations, as Meg just highlighted, you know, even though there's space, I've heard of so many of you providers being able to actually get in the darn home of one of your kiddos and see what it's like. And that's a tremendous gift and a silver lining of this. So how can we figure out how to have all that go forward? So with that, if we can move to the next slide, and I'll invite, oh yeah, go ahead, Meg.
I'm so sorry to interrupt. Just before you move on, there was a question in the chat box. What does the spiral?
Oh, yeah, sorry. Thanks, Tammy. Yes, Libby had reminded me yesterday, Kara, you got to describe your art. Sorry. Thank you. Okay, so I'd like to think of my artist, but clearly I'm not. So the spiral was, thanks, Tammy. That was a telephone cord showing that medical care is connected through some sort of audio, visual, texting, whatever, digital, you know, through, it's old school because it's not in person, but it's really not old school. It's new, it's innovative. It's meeting the needs now. And we're all beginning to talk about how do we keep this going forward and make the balance. So those are the phone cords that, you know, the F2Fs are supporting through technology as well. And schools are doing some sort of distance teleconnection and stuff too. And I have questions by mental health and work and food and housing and safety. And these are the great unknowns that, you know, our families are experiencing and we're all experiencing. And how do we come through this together? And I put social there. Originally, I had friends and kids, you know, wanting to reflect how our kiddos with medical complexity have lost their school connection potentially, and how else are they doing? And so they're tweeting, snapping, and Insta and Zooming, but so are we, because hopefully we've all partaken in some Zoom happy hours and other stuff. And then the supply lines are dotted lines because those are not, the supply lines are not what they used to be. And then home health, I was saying, are we yielding, holding it at bay, or stopping it? And with that, I can transfer right into and invite Debbie Harris. In the next slide, she's going to walk you through sort of some of her thinking of the Harris family that we've all come to know and love in the CoIIN, and sort of how they've talked through and walked through through this great communication internally with their family and their providers. How do we do this in this emergent pandemic time? So Debbie, take it away.
Okay. Can you all hear me or see me or anything?
We can hear you. Yeah.
Okay. It says video, but I don't.
I can see you.
You can see me?
Yep.
Okay. Well, wait a second. How about now? You can see me now?
There you are.
Okay. All right. Well, anyway.
Debbie, if you are able to move, so if you angle your device down just slightly, we'll be able to see your mouth. There we go.
Oh, I see. I can't see where I am.
Yeah,
so
I know. It can be tricky sometimes.
Okay, wait a minute. I have no idea what you're looking at, so that's really weird for me. But
okay, well, you carry on. You're doing the best you can here, and we can hear you, and we are seeing a good portion of you. So
I don't know what portion it is, so that might be odd.
Definitely the best portion.
Okay, then.
Oh,
okay.
Wait, that did something. Do that again. Yes. Yeah.
Yes. Oh,
yeah.
Wait. Okay, wait. All right. Sorry to use up time like this, but usually I can see what's going on. All right. So if you look at the photo on your right, look at the looks on our faces. That's pre-COVID, and look how we look so unsuspecting. So we don't know what's coming, and we look so happy and so calm. So that's my family. Those are our three boys, Josh and Nick and John, and my husband Victor, and our little dog Claire. And this is right before everything kind of blew up. And it is a little bit, I should say, deceptive, because we're really not, our lives are not calm or anything ever, but this is the best we can do. So this is our rendition of the calm pre-COVID Harris family, and it is difficult to get a photo of us because my husband does not like to take pictures, but we did get him in the photo. So this is pre-COVID Harris family, and we're all organized and everything is just in order. So that's us pre-COVID. But I will say this, I wanted to talk about Greg's comments and the 9/11, and that was emotional for us as well. It seems that we're accustomed to, let's say, surprise and a bit of chaos, and I should say, kind of difficult events in our lives. And first of all, when Josh was born, that was a surprise in that we didn't know, you know, what kind of journey we would be on, and we did try to make the best of it. Before Josh was born, however, when 9/11 came, you know, I had an idea that we'd be entering a different time in our lives as well, because my husband was in the Marine Corps he's a career Marine. And so when 9/11 came, it was tragic enough, but in the back of my mind, I thought we are about to head on a really difficult journey. And we did. And so, actually, I'm sorry, Josh was born, I'm sorry. We were about to head on a really difficult journey. And so after that, my husband was deployed to Kuwait and Iraq. And so we had to learn to accommodate and adjust, and it affected everything. It affected our nursing, it affected our mental health, our emotional health, it affected everything. And at that time, the boys were much younger. And so, you know, my husband being away cumulatively for about 3 years of their lives, and in such a difficult situation because it turned out that he was in kind of the midst of combat in Fallujah. It was really hard on everybody. And at the time, because we had to switch resources from his corporate job to military, we lost our nursing for one of the deployments, and I had to just stay up myself for days at a time to care for Josh. And so we're kind of accustomed to making things work and living through them. But then you think, well, that was hard enough, so I should be kind of free for a while. And then you get like a plague that comes later on, you know, because you have to still do more. So, but I think for families of children with medical complexity, you become, excuse me, accustomed to adapting. And in this case, for Joshua anyway, we were already kind of in our winter mode of kind of isolation and trying to keep him safe because it was viral season. And so we were already in that mode as we went into this kind of COVID era. So we were kind of headed there anyway, but it did present a lot of challenges for us. And so when you go to my home care after COVID map, and it talks about organized chaos. And one of the things that Greg said was when talking to families, he talked about qualitative data and how important it is to really talk to families, because you're not going to necessarily find out what you need to with aggregate or quantitative data in a situation like this, because there's so much that's unknown. And so I thought about Lorenz's theory on deterministic chaos. And I'm calling it organized chaos for us, because as you see, even though this looks chaotic, there are still anchors on each of the four sides. But here's the theory, and I actually love this. Chaos is when the present determines the future, but the approximate present does not approximately determine the future. So because we have an approximate present, as you all know, things change every day. We cannot approximately determine the future. It's an approximate future. We don't know what's coming. So you just make it day by day. And our kind of, I guess, system of living anyway in the Harris household is taking everything 20 minutes at a time. So We do plan on a macro level, so we make sure that we do that, but we realize that everything can change on a micro level all the time. And that way we're not so disappointed. So a couple of things that have happened during this particular COVID journey are listed here. So one is that when this whole thing came up, our nursing agency was radio silent. Absolutely no support, no information, nothing. They came over and they handed out a couple of brochures to the nursing staff about how to clean their desks in the office and that kind of thing, but nothing for families, no support, nothing about how to keep families safe. You know, if nurses got sick, if nurses were exposed, nothing like that at all, nothing about PPE, nothing at all. And I'm thinking it's because they didn't want their business to slow. So we were on our own, and we realized that from the beginning. At the time, we had a nurse trainee who was had already put in about several, excuse me, several shifts of training, who we absolutely just loved. But he also worked at a main hospital here in the Twin Cities, and they had established one of the first COVID units in the Twin City area. And even though he wasn't on that unit and didn't work directly, I'm sorry, directly with those patients, the other nurses were concerned about exposure, not only to themselves, but to the family and to Joshua, and how that might affect everything. And then, so we kind of all met about it, made a determination that maybe he should start later. And he was upset about that. I didn't realize he had actually cut some of his hours in order to put in, he was only going to work part-time in order to put in hours here. The reason that I was bringing him on is because I was already exhausted. And so I was already doing like my shifts of like 14 hours on Sundays and maybe 12 hours on Thursdays, and also managing Josh's case, which is a full-time job in itself. And then I found out that he was also working at an assisted living facility as well, which in Minnesota, if you've heard, is like those are our areas of the fastest growing COVID cases and deaths in Minnesota. So we didn't find that out till afterwards, but we do provide a bonus for our nurses to get their commitment to stay with Joshua and to provide consistency on his case. So what I did was I gave him his bonus up front to kind of mitigate his cutting his hours, and it was a hefty bonus, and then promised to save his hours for later. So basically I paid him off. So he'll be coming back when things slow down and are safer. The next thing we did, we had gotten literature from various research groups and this group and whatever, and we just went full throttle on infection control precautions. So we have done everything we could as far as keeping Josh basically isolated to one floor of the house where his nursing area is, his bathroom, the family room downstairs. Upstairs is where a lot of deliveries come in. People are coming and going, even if it's just family, just so we could actually control something. So we keep him in that area, but he doesn't have to stay in one room. And then we make certain that we keep that particular area completely, as far as we can, as much as we can, germ-free. Josh is really upset about it, so I wonder how that is affecting him. And now that it's nice outside, we're gonna try to get him maybe outside a little bit too. But for the winter, it was the best, I think, the best plan. I think that the other thing we did was ask that the people that were caring for Josh make a commitment to social distance and self-isolate if they needed to, so that we didn't have that additional fear. But I was really stressed out about it because we had a number of caregivers. We have 2 nurses who work full-time with Josh, but he is their only client. and you don't really know what they're doing after they leave. And I trust them. However, little things would come up, like our night nurse would come one day with his hair really long and then the next day with a professional haircut. But then he would have like a hat on so that we wouldn't notice, but of course we noticed. And then you're like wondering, well, how did you get that haircut, you know? So I felt like they're like kind of cheating on me, and any day we would all come up with coronavirus and that would be the end of us. So it's just scary because there are things you can't control. You don't want to like follow people around with a spray bottle and just spray them with disinfectant and ask them, you know, what are they doing outside of their lives here? But yeah, you do want to ask them actually, but I don't want to be that invasive in their lives. We actually have to use family members to help with Josh's care because we don't have enough providers to do 24/7 care, awake care, which is what Josh needs. And so my brother was working with us because he's an artist, a graphics animation artist. He works with the theaters in town, the Guthrie and various theaters in town. And so when all of those productions shut down, he's out of work. So he's working here and he's coming and going. And I was concerned about that level of exposure as well. The anxiety got to be too much for me. And so when the CARE Act was passed, and then also there's some grants provided for artists, we decided that it would be financially better for him to just take advantage of those grants for artists and the CARE Act, and have him just kind of sit out for a while as well. And then I paid him his bonus for the half year, and so he's gone as well too for now. So those outside resources really helped my anxiety, but then it put more burden on the family to provide care during those hours where he was helping us out, which included night shifts as well. And so now our older son, Nicholas, who is standing in the picture, he works full time. He and his wife have 2 small children, and he's coming to help us out as well in evenings and some night shifts because we have no nursing on the weekends. And so now he's telling us the other night, he's like, I'm really wearing out now. So that's another thing. It's the exhaustion and not knowing, you know, when does this safely end for us? You know, it might be like a proclamation that, you know, we're opening up and it's safely ending for this group or that group, but not for us, where, you know, we have my husband who is in all of the risk categories and Joshua who's at very high risk. So how long can we continue this when we're actually wearing down the people who are helping, helping us sustain this crisis? And then the last couple of things are telehealth has actually helped us. We have a physician, one of our surgeons, Josh is otolaryngologist, who actually has been with him since he's been about 3 months old, actually was retiring this month. And so our last appointment with her was this month in May, and we were able to have a visit with her, but it was through telehealth. So we weren't able to see her for that last visit, but they did an excellent job through our children's hospital. And they used an app, and I can't think of the name of it right now, but it had a waiting room. You registered, you had a waiting room. You didn't have to use, she didn't have to use her phone number. She was able to be in her home. I was in, you know, we were in our home, of course. I was able to share, you know, Joshua with her and his surroundings. And we were able to really talk about the last 27 years and how she really made it possible to have Josh in our lives. We both started crying. I mean, it actually was nice in that we didn't have to be professional. She didn't have to have medical assistants or nurses coming in and out. And even though we couldn't be right there together, it gave us that opportunity to share in a way that we wouldn't have been able to. And we unfortunately had to say goodbye that way, but I think it actually was for the best because we could both be ourselves in a way we wouldn't have been able to in a clinic setting. So telehealth in that way worked for us this time, and I'm so glad we had the technology to do it. And then our last thing is we have one night nurse, we have one day nurse, and they both work about four days a week. So our night nurse is heading to Michigan, which I think of as a growing coronavirus setting. And he's going to a bachelor's weekend. And I'm really concerned that we're just not going to have a night nurse when he comes. So those kind of things, you just feel so out of control and vulnerable. And he says, well, maybe I'll just get a test before I go. And I said, no, I think you should get a test when you come back. So things like that, you don't have any level of control. You can't tell an adult what to do. You just hope that, I don't know, everything works out for the best. And then, live life 20 minutes at a time. Isolation that we felt before, we're kind of a bit used to it, but now it's exaggerated. And, our nurses are actually our access to the outside world, our nurses and our son. And so we don't even go to the grocery store. We order and have it brought in, and we're the people that you see on the internet that are spraying their groceries down and wiping them off and leave packages on the back porch for 2 days. We do everything like that. And so we ask the nurses, like, what is it like out there in the outside world, and tell us about it. And so, how is your mother? What did she cook tonight? That kind of thing. So, I think I might be losing it. Okay, so the isolation is difficult, but one thing we have done is I have a few friends, and all of our boys who have complex needs are the same age, and we've been able to support each other by having a weekly Zoom call, and that's been actually really wonderful and nurturing for us. And so, like what Greg was saying, just ask families, like, sometimes respite is a big word, and when you think about having people, like another person, come into your house, you don't want a stranger coming into your house right now. You can't train that person in. That person's going to go away anyway when things resolve. So sometimes respite might mean something else. It might mean access to an iPad, so you can do Zoom calls, or it might mean just, I don't know, getting a air mattress so you can sleep on the floor right next to your child's bed, or, there are a lot of things that respite can entail that means it's not necessarily a person, but just a way out temporarily until you can gather your strength again and make it through this particular crisis. And that's what we had to do after 9/11 happened. For 3 years, we had to do that. So hopefully we'll make it through this crisis as well. So thanks.
Thanks, Debbie.
Yeah.
We can open it up here for questions, but one thing I just wanted to kind of point out again, or I know Debbie, several people asked, and maybe you can write down for us the quote that you gave, the theory you gave at the beginning. And I think there's so many wonderful things about when Debbie shares her story and teaches with it, but that she's calling this organized chaos. I think that is something why I asked her to talk today, is because just listening to that, I feel my pressure going up. I feel PTSD to being through these situations. We all do. Everybody's relating, and like, yes, I had 5 patients yesterday tell me the same types of things, or, we're all relating in many ways. This is super emotional. It's chaos. But what Debbie shows so well is that it's organized chaos. This is a very well thought out care map, even though it looks chaotic, and I'm not ripping on your artistic skills because they're much better and more colorful than mine, Debbie. But just that, the skill that, that families of kids with medical complexity tend to have more than other families, or families, and not comparing, but just there is a skill to this lived experience that Debbie has articulated so well today, where, they know how to manage in 20 minutes at a time, and then the next step and the next, and there's a lot of thinking, that happens in the 4 walls of the consult room and then well out. And now with telehealth, you're able to come out and join in with Debbie and the Harris family, as she was saying, through telehealth, and kind of plan and think through, how do you do these kinds of things? So there is, you know, and when patients and families are sharing these things with you, you know, your immediate reaction is like, oh, how do we solve? But as Greg commented, I thought one really great comment he made about the data was looking at, okay, when you shared about your experience, was this just that day, or is that overall with the experience, and taking the time to really explore what that means? Is this your isolation you're feeling? Is that overall, do you need enough supports, or what is everything else you're saying? So I see there's a whole bunch of chat going on, and Bethlehem, I'm not sure where we are in timing and stuff, but Debbie and I are done talking, or we can facilitate questions or whatever goes next.
Well, I appreciate that. Thank you so much for sharing, Kara, and for Debbie. You just have such a way of really helping to get into the breadth and depth, and yet also bring us back to the larger picture of what's happening all at the same time. Like you just, like, you're going through all of it all at the same time. And I think that it's very powerful. So you got a lot of accolades in the chat. So you're aware, people really appreciate the consideration about just the organized chaos theory, and want to have that in hand. So we'll ask if you can share that. Consideration around the 20 minutes at a time, and thinking about that, what you're demonstrating is that resilience and coping that we're talking about, and we need to figure out how we now use that to inform and have the system work so that you do have families are getting those respite moments in the way that work for them, and they can continue, and that there's less that there's more of that available within the system, so you don't feel like you have to, the families need to take it all on, that it's more of they have the full options of choice, even in the crisis moments, right? So I also see on here online mindfulness classes is being discussed. The whole visual of the care map, people are really appreciating that, and how they could use the care map to understand their own mental health and help them remind of what they're doing. There's a lot in here. What I want to do is just see if there's anything anyone wants to speak to now on what Kara and Debbie have said. We do have some questions that came from state teams that we wanted to have a few minutes to get to. What I'm thinking is we might end up needing to follow up with some of those, because this has been just in the way that we're trying to be responsive to the moment right now. In each 20 minutes, these 20 minutes have been 20 minutes that we wanted to keep as they are. And so does anyone have anything they want to say? There was a lot in the chat. If you do, just please go right ahead.
Bethlehem, this is Kara. I just, not that you guys want to hear from me again, but I just want to pull out Vera Spink's comment that this makes her, you know, want to do a care map for herself, to help herself understand, what do I need to do to put my oxygen mask on first and stuff. I don't know, Vera, if you want to speak to that, but I think that care maps are such an underutilized tool in a way that we could come together and figure out how to bridge the chasms and to help families organize themselves and stuff too. Vera, if you want to talk to it, otherwise I pulled you out because that's a great comment.
Yeah. Am I echoing to you guys? Or no?
There's a little echo.
I'm not sure why. Okay, so you know, it helps us when we do just our original care map. I mean, there's a lot of things that are freeing in that, because we feel like we're failing so big time, as, you know, I'm not doing enough. And then we realize, you know, where our supports are, how much we are doing. And I'll say you know, we all have our seasons. For myself, coming out of a season last year of a whole year of 21 neurosurgeries for my daughter. And I just wanted a time of health and wellness. And we almost got there. And then COVID, like, hit. And so I thought I was holding it together and I was coping, and then I realized I really wasn't. And so the PTSD, I'm finally recognizing my triggers, and some of those are even mask and wearing mask. And now all I see is sickness when all I want is health for my daughter. So in her own season. So anyway, I think it would just be very helpful for us, even with our families, to do these. I know for our state team, I've asked, could we have someone from our CoIIN project have a family being served in our, you know, the center, to be able to do one of these, so we can see those telephone, you know, cords and the dashes and the supply. so we can meet those needs they have, not assuming we're, we know what they need. So.
Thank you, Vera. Kara, thanks for sharing with your whole heart and your experience as well. There was a question for you, Debbie. Did different shapes in the care map mean something, or are they just random?
You know what? It was about 3 o'clock in the morning, and I got a new iPad, and I got an iPad pencil for Mother's Day, and I was just playing around with it. Sorry, I wish I could have a more professional answer, but I don't. I was going to make something up, but I decided not to.
That is the perfect answer, of course. All right. So I think that we've heard the concept of using that care map and using that as a tool to help to inform how to support families. Kara, did you want to say something else? Okay. We did have, this has been, really appreciate this portion and the sharing and Debbie's joy at play, as the chat box talks about. We're going to move into the next portion right now. It's kind of hard to transition here, but we had some questions that state teams had that related to trying to really engage with families and trying to figure out the best ways to have conversations with families in the most appropriate way right now. And some families have had trouble connecting with their patient population, and I don't know if they want to speak to that. I have here, sorry, I've got to move up my agenda to be able to see this. So Kentucky had submitted this question. I don't know if there's anything more you want to speak to ask the group about in consideration of this, or if anyone has anything to want to say to try to, in their experience of trying to reach out to families. So what we can do too is put this out to some of the listservs to see if anyone has anything they might want to add. But has anyone had any ways that they've been able to try to reach out to families that have worked well for them? I know someone said that they've just been able, we had some conversation about this at the beginning in different strategies for just the pragmatic getting people to pick up the phone or texting. Okay.
Jessalyn, this is Shonda. I would like to
call on you, Shonda. This is Tara. I was giving you a few minutes and I was going to say, Shonda, you've done some amazing
It's funny,
work.
I couldn't find my unmute button and I kept going to chat. I was getting frustrated within myself.
There she is.
You must have been feeling it. And so one thing I'd like to say is there's a couple things I noticed early on. First, when COVID started happening, Cindy, my partner and I on the CoIIN, we noticed that everyone was picking up the phone. I mean, it was just like, we were getting so much response, and it seemed like it didn't matter what time of day we called, we were getting phone pickups. And so there was a lot of engagement. Then we noticed that kind of a bell curve where kind of waned. And then I noticed that there was a definite, obviously families were getting taxed. And what I've been doing is I will put in a phone call, I'll leave a voicemail, pretty short and brief, and then I will follow up in the next 10 minutes with a text and say, hey, just so you know, this is Shonda who just called, just in case they're screening their calls or they don't recognize my number, or they've just had too many auto robocalls for the day, or they're just tapped out and they can't talk. And I would say 8 times out of 10, I'm getting a text back that says, oh, hey, how's it going? Yeah, now's not a good time. How about tomorrow morning? Or I didn't know it was you, yeah, is text okay? Because my kids are crazy right now. So we can't assume what their life is looking like minute by minute. And I just want to give them all of the options for connection. The other piece is that we did start the Facebook group in the past month. Within 3 days, we had 19 signups, which is, I think, was a really huge boost to our team. We had 19 families immediately sign up for the Facebook group and say, yes, we want to connect. It really kickstarted the virtual parent support piece. We've had more engagement. Cindy and I are also looking into doing a COVID-specific parent support where we just talk about how COVID has changed our lives and how we're able to, you know, breathe during this and give each other some support, peer support. So we've been using everything given to our disposal. And then of course, you know, not everything works, but for the most part, the texting piece after I call, I mean, that's a huge thing. Just say, oh, you know, I didn't even listen to your voicemail. Thanks for saying it was you. You know, right on, let's talk. So that's what's been working for us. Cindy, do you have anything else to add? Are you still on?
Yeah. Hi, everybody. Yeah, I'm still on. Yeah, just like Shonda was saying, in the beginning, a lot of folks were answering their phones, and now I have seen a bit of a drop off. Like Shonda was saying, you know, sometimes, you know, we'll call them, we will leave them a message. And texting, I have found, is a really great way to communicate with our families. And with this new Facebook group page that we have, I think that's going to also be a great way to communicate with our parents, because everybody has their phone on them all the time, and they can log into our group and ask us questions. And so we're really excited about that. Like Shonda said, within the first couple days, we already had 19 families that signed up for our group. So we're excited about that.
This is Jill. I just want to let folks know that sometimes there's a concern about protection and safety around things like Facebook. And for this particular project, we made it an invite only. So it is a Facebook that all of our enrollees are invited to participate in. It is not open to outside folks at this point, other than people that we connect for information. But I think the sustainability of this particular group is that once CoIIN is over, we work and talk with the families and ask, do they want to open it up? Do they want to make it under F2F a more open Facebook for young families in their journey and to share as part of leadership development?
Great. Thank you so much for sharing about that, Team Washington. I hate to say this, but we need to wrap up. It's just, there's been so much good stuff to talk about here. I'm going to bring us right back down to the end here, where you can see we were prepared to be able to ask other things. So if we could, we have here a webinar. In the meantime, pop-up webinar topics. We're going to put a poll out. In the meantime, Libby, can you also please put out the in the chat the evaluation survey link? If folks could quickly just see which of these might be a useful topic for you, we'd like to just take your quickly take a poll on this. And then please know while we're doing this, Ben, if you could speak to some of the things for people to know about.
Yeah, for sure.
Next steps, just quickly.
Yep, so thanks for attending the webinar and sharing your stories and questions and thoughts, especially on the COVID-19 measurement and ongoing support for families. So just a couple things that we have coming up. We are planning the consultation visits. So both the BU team and the IP coaches are going to be contacting you about that. Remember, they're all going to be virtual. We're also, as you can see, we're putting out this poll right now to come up with our next idea for our COVID-19 pop-up webinars. So as soon as we have that planned, we will reach out to you about that. Thanks everyone for joining the Echo yesterday. And if you have not been able to be a part of that and would like to, please reach out to me or someone else at the BU team. They're every other Wednesday. So not this coming week, but the next week is our next one. And finally, we are starting a telehealth measurement work group, so kind of around what we were talking about here. And if you would like to be involved with that and have not heard about it, please reach out to one of us as well.
Great. Thank you, everybody. We are going to end our poll. It looks like we've got some particular things that people are interested in, and it's pretty close. So we'll take this into account so we can do the next pop-up. And sorry to go a few minutes over, but we appreciate the robust discussion. And as you know, there will be more. Reach out anytime, and everyone, please take good care. Be well. Know we are all there for each other, and keep up the excellent work and thoughts. And if there's anything else, we'll leave chat open. So if anything else comes up for people, please feel free to chat it into the chat box, any lingering thoughts or questions. And we will make sure to follow up and consider everything that we've been covering and talking about. Thank you.
Thanks, everybody.
And thanks to our presenters. We really appreciate your time today, too.
Bye, everybody. Thank you.
Bye, Mary. And bye, Greg. Kara had to go, too.
Bye.
Bye, Debbie. Thank you so much.
You're welcome. Stay safe. Okay.
As we usually do, we'll keep the room open for just 2 more minutes so people can fill out the evaluation.
Libby, does Zoom automatically save the poll, or should we take a snapshot of it?
Automatically.
I took a snapshot, but it also saves it.
Oh, fantastic.
Covering both bases.
Back up.
Great.
Okay, team, I'm going to hop off and I will meet you all again at 3 o'clock on Anna Maria's conference line. Well done, guys.
And Meg.
Thank you.
But good job. Good job.
Bye, everyone. I think I'm going to close out the meeting now. So,
Great. Thanks, Ben. Thank you, everybody. Take care.
everyone.